Okay, we are going to get started, and welcome to the North American Neuroendocrine Tumor Society monthly virtual programming session. This time, we are focused on rare neuroendocrine tumor updates with a particular interest in pheochromocytomas and paragangliomas. I am Camilo Jimenez. I am professor of endocrine cancer and hormonal disorders at the University of Texas MD Anderson Cancer Center in Houston, Texas. It is my pleasure to moderate today's educational webinar. Our featured speakers will give a presentation, and then we will engage the audience in a question and answer discussion. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education and the American Nurses Credentialing Centers Commission on Accreditation. Please earn AMA PRA Category 1 credits and nursing credits. A link to obtain credits was provided by email to all registered attendees today, and we will also be provided post-webinar. NANETS is committed to increasing diversity within our activities and structure to reflect all aspects of the neuroendocrine community we serve. We strive to cultivate an open, transparent, and supportive culture where all are welcome. We encourage members to contribute and participate fully. For more information, please visit nanets.net. Now, it is my pleasure to introduce our speakers and case presenter for today. Today we have Dr. Nida Pandit Tashkar. She's an attending physician at Memorial Sloan Kettering Cancer Center in New York, and she will be speaking to us on imaging and MIBG. Then we'll have Dr. Kimberly Perez, who is Assistant Professor of Medicine at Dana-Farber Cancer Institute, who will present on existing landscape and recently reported data on pheochromocytomas and paragangliomas. And lastly, we have Dr. Vineet Sukritan, who is Assistant Professor at The Ohio State University, who will be speaking on ongoing clinical trials and future trials. Following the presentation, we will have a question and answer session. Please place your questions in the question and answer box for our moderated discussion. With that said, let's get started. Dr. Pandit Tashkar, the floor is yours, and thank you very much.
Thank you, Dr. Jimenez and NANETS. Okay. So I'll be talking about the targeted radiopharmaceutical therapy in treatment of pheochromocytoma and paragangliomas that partly includes how we image and what target we aim to use in treatment of these patients. These are my disclosures, and
we don't see your screen just yet, Dr. Tashkar.
Oh, sorry. Do I need to do anything? I did hit the button share.
Just share screen and then select the screen that has your PowerPoint open on it.
Are you able to see now?
Yes, we are. Thank you.
Okay, great. So I don't know if you needed me to go back. Okay, so here are my disclosures, and these are the objectives. Overview essentially will go over the agents, mainly focusing on Ezetra or iodine-131 MIBG, which is the FDA-approved agent for therapy of pheochromocytoma and paraganglioma, an overview of how it stands in terms of NCCN guidelines and recommendations, some clinical background on the key studies, and then practical aspects of administration and just some case examples. When we look at NCCN guidelines in terms of where we can apply the radiopharmaceutical therapy, essentially we see in patients who have locally unresectable disease or patients with distant metastasis, the recommendation is that iodine 131 MIBG therapy can be performed, or one can consider PRRT with lutetium dotatate. If, of course, for both, you have to demonstrate that the disease is positive or avid on the imaging component of that allows us to understand targetability and eligibility for treatment. And similarly for patients with distant metastatic disease. MIBG, as we know, is essentially an analog of noradrenaline. It targets the norepinephrine transporter. And previously we had what we call as conventional MIBG, which was low specificity, and Izidra is a high specific activity agent of iodine 131 MIBG. And in parallel, we have the somatostatin receptor targeting agents such as the lutetium 177 dotatate or yttrium 90 dotatalk. Just to mention that previously, prior to approval of Izidra, much of the treatment with iodine 131 MIBG has been done using the conventional dosing schema, where there have been variation in amount of doses given, mainly less than 200 millicurie being a low dose, intermediate doses greater than 200 millicurie or so, and high dose treatments with 12 millicurie or higher, mainly seen in pediatric patients with bone marrow support. And then lower dosing has mainly involved multiple dose administrations. Subsequently, following systematic assessment through multi-center studies and phase 3 trials, iodine 131 iobenzine or Izidra has been approved in 2018. Specifically, the indications are adult and pediatric patients 12 years and older with unresectable locally advanced metastatic pheochromocytoma or paraganglioma who require systemic anti-cancer therapy. As mentioned, you need to show through imaging that there is positive disease, and it involves dosimetric estimations, which I'll be showing in subsequent slides. And again, not to go over too many details, but the high specific activity agent Izidra or iodine 113 iobenzine has larger amount of activity tagged to the cold agent or the small molecule that basically targets or delivers higher radiation to the mass amount of administered dose of the agent itself. Phase 1 study evaluated what the maximum tolerated dose would be in patients, and the MTD was determined to be 296 megabecquerel per kg. The highest mean radiation absorbed dose was to thyroid and intestinal walls, saying that the biodistribution to other organs is not that high, so we would have lesser side effects. The best biochemical responses in as relates to complete or partial responses for serum chromogranin A and total metanephrines were observed in 80% and 64 patients respectively, and overall survival was about 86% at 1 year and 62% at 2 years after treatment. 84% patients had some adverse events, but they were mainly grade 1 or 2 with full recovery, and most frequent hematologic side effects included neutropenia and leukopenia. Subsequently, a larger study, a phase 3 multi-center study, essentially looked at 131 iodine MIBG or Izidra with a primary endpoint of looking at the 50% reduction in baseline antihypertensive medication lasting at least 6 months. Out of the 81 patients enrolled, 68 received 1 dose and 50 patients received a second dose. When you look at the patient characteristics, you can see that many of these patients were heavily pre-treated and also actually had prior treatment with iodine 131 MIBG, which is very interesting. And of course, there were patients who had both soft tissue disease as well as bony disease. A significant number of patients met the primary endpoint and were responders. What is also interesting is that those who were non-responders by the primary endpoint, when we looked at the RECIST criteria, they also showed significant decrease in the percentage change from the baseline sizes of the lesions by RECIST criteria. So overall, you see that when we combine stable disease and partial responses, about 98% responses following 2 therapeutic doses. Overall, the partial response with 2 therapeutic doses was higher as compared to ones who received only single therapeutic dose. And you can see the same in this graph here, patients with single dose and their survival curve as against the ones who received 2 doses had a higher survival. And as noted here, the median overall survival was 36.7 months. Again, main toxicity was related to hematologic toxicity. A majority of those were lower grades, but there were grade 3 to 5 toxicities related to hematologic toxicity seen, and majority had full recovery. When it comes to dosing, there is a dosimetric estimation required that requires scanning the patient at 3 time points. Overall, essentially 500 millicurie of dose is the recommended flat dose that is given 90 days apart. For patients who weigh more than 50 kg, initial imaging dose is 5 to 6 millicurie. And patients less than 50 kg, there's a separate or lower 0.1 millicurie per kg dose for the imaging. And similarly, the therapeutic dose is also adjusted based on the body weight. And also, of course, if you have hematologic parameters that do not meet, you have to scale the dosing down. But otherwise, as long as you meet the parameters as mentioned here, you can give full dosing as recommended. As mentioned, 3 scanning time points are required to do the dosimetry. One is on the day 0, and then a second scan is performed day 1 or 2 post-injection, and the third scan anytime between 2 to 5 days post-injection. And you essentially perform anterior and posterior whole body images, and then the standard can be placed on the side as noted in this patient scan here. And of course, there are multiple areas of increased uptake suggestive of avid disease that can be targeted with 131 MIBG. The instructions are that following the dosimetric estimate, you would look up this table and see if there are if the dosing estimates to the organs meets the required limits, is within the limits as mentioned here. The bone marrow dosing that is more critical is, as noted here, is beyond the standard 200 centigrade that is noted for most of the other imaging or dosing components. And then, of course, you have to reduce the therapeutic total activity if the organ dosimetry exceeds the levels, so that you can modify and keep the administered activity within the required dosimetric estimates. Again, as mentioned, if there are hematologic toxicity or there is drop in the counts, there is dose modification whereby we do not administer the dosing, the first dosing if the platelet count is less than 80,000 and if ANC is less than 1200. And then for subsequent dosing, again, if the counts are lower than 25,000 for platelets, we do not administer. Similarly, ANC of 500 is limiting. Other side effects like febrile neutropenia and active bleeding would require us to not give the dose. And again, here's the dose reducing schema for patients based on their weight with a reduction of 85% or more. Just to show some examples, in this patient, this was a male with hypertension and symptoms of abdominal discomfort who presented for consideration of iodine 131 MIBG. And here you can see a baseline scan. Patient had avid node in the left lower neck or paratracheal region, and a bony lesion along with soft tissue in the upper vertebra, and a recurrent disease. The patient actually had his primary tumor resected several years ago. And the iodine 131 scan, you can see serially following first treatment, you can see decrease in the uptake of some of the lesions here, and definitely a significant difference following the second and third treatment in this patient. This patient was treated with more dose fractionation on an that allows for outpatient dosing using 250 millicuries dosing. The patient's symptoms, the hypertension definitely decrease is required from medication, decrease his free metanephrine decrease from 255 to 3.2 following 2 dosing, and chromogranin A decreased from 1,778 to 238. The patient is now continuing to be followed up and is essentially showing stable disease following these treatment for almost 2 years now. And I do like to perform FTG PET scans in these patients just to see, sometimes we can have discrepant lesions, and also you can quantify and show differences. So here's a scan, a baseline scan, and after 2 treatments, the uptake in this adrenal lesion has gone down to 30%. Not sure why they can't advance. Okay, sorry. And just another example in this patient, you can see multiple foci of uptake in iodine 123 MIBG scan, and follow-up after 4 fractionated dosing. There's significant decrease in uptake in the lesions. And again, there is a drop in the total metanephrine and catecholamine levels. Patients' pain in the back decrease, and here's an FTG PET scan that shows significant decrease in uptake in several osseous lesions. Another question about whether you use PRRT or iodine 131 MIBG. A panel of experts put together their opinion. Essentially what it is that there may be lesions that there may be disease that is more avid on iodine 131 MIBG or 123 MIBG, as in this case where you're seeing more disease as compared to the DOTA-TATE scan, in which the logical approach would be to use iodine 131 therapy. And as shown in this example here in this patient, again, there is a drop in the FTG PET scan burden and a significant decrease in disease. But you may have, and again, similarly, in this patient, you can see that the DOTA-TATE scan is showing a few areas of uptake, but clearly much higher disease on MIBG scan. And this is also seen on the FTG PET scan. Again, MIBG would be, treatment would be of choice. Conversely, you may have situations where DOTA-TATE imaging is showing higher, similar or maybe higher disease burden, and when it's similar disease targeting status for both, the choice becomes a bit difficult. And then I think the fact that the iodine 131 MIBG is FDA approved, one may have more convenience in treating with that agent as against Lutathera, where you may need to get approvals for insurance coverage, but either one could be used. And again, not going over the details of this table, but certain parameters may be more suitable when it comes to deciding whether you use iodine 131 MIBG or lutetium 177 DOTA-TATE for treatment, such as renal disease patients who are older or have more marrow, less marrow reserve may be better treated with the lutetium 77 dotatate. Also, we know that a subgroup of patients with SDHB mutations tend to have higher propensity for the somatostatin receptor as against iodine 131 MIBG imaging, where the disease may not be targeted or shows low avidity. And in these cases, the obvious choice would be to treat with lutetium 177 dotatate. And just to end quickly, some logistical aspects in terms of the inpatient treatment and lead-lined rooms, which pose a significant resource limitations for centers. One could actually administer in non-lead-lined rooms using the mobile lead shields. So with that, I would like to conclude to say that the MIBG therapy is currently approved, FDA approved treatment for these patients. It requires individualized, personalized dosing. Inpatient therapy logistics can be variable across the centers, but various approaches are possible, and the administration of this treatment requires coordinated efforts of multidisciplinary services. So with that, I would end this talk and happy to take questions later.
And thank you very much, Dr. Pandit Lashkar. That was very, very informational. Now, I would like to pass it on to Dr. Perez. Welcome, Dr. Perez.
Thank you, Dr. Jimenez, and thank you to NANETS for inviting me to participate in this webinar this evening. So I've been tasked to provide the recent updates for this disease. My disclosures just include that are included here. Objectives for my discussion today will just be to review the novel therapies that are available and discuss some of the molecular markers that may guide treatment options. I just want to start, my first 3 slides are just background, and I find that they're very useful in providing guidance as to what therapeutic options are going to be available, and kind of will pull us into the rest of my discussion. But obviously, first and foremost, we're discussing patients with pheochromocytoma and paragangliomas. The most common, this disease is a disease that arises from the chromaffin cells of the adrenal medulla, and you develop the pheochromocytomas, or else you have the development of disease within the sympathetic ganglia, and you'll have the paragangliomas that are within the abdomen, mediastinum, or in the head and neck region. And I just bring this up because treatment and prognosis and molecular markers do vary based on site. The other characteristic that also can drive or direct therapy is the clinical features. So as we all know, symptoms are present in approximately 50% of patients, and this is a result of the excess in catecholamine release from the tumors, and can result in a variety of symptoms. The triad that is most commonly described is excessive sweating, anxiety, and hypertension. The third characteristic that it has been described and utilized probably more recently is the idea behind the genetics or the molecular profile of this disease. And so what has been described are the 3 clusters, so cluster 1, cluster 2, and cluster 3. And this is really designations that are based on somatic as well as germline mutations in the particular genes and how they contribute or partake in the pathogenesis of the para and Pheos that develop within or characterized within these groups. And as a result, we've also, in grouping these patients' tumors into these different clusters, we've also been able to determine that there are prognostic significance to these categories as well as therapeutic implications in these categories. So I'll move on now to the management and some updates there. So again, background. This is a disease that is very much a multimodality treatment paradigm, where you do have surgical debulking. We do also use cytotoxic therapies, targeted therapies. We're investigating the role of immunotherapies, and as Dr. Pandit Taskar had just reviewed the radionuclide therapy options. And here is just an algorithm that can be applied to patients with this disease in the metastatic setting. So again, first and foremost, because 50% have functional tumors as a result of catecholamine excess, we want to focus on the alpha adrenoreceptor blockade. Then after those symptoms are well managed or controlled, we want to get a sense from burden and rate of growth, which one of these pathways we're going to travel down. And it can, again, the multimodality approach of including surgery or radiation or ablation, tumor-directed approach, or are we looking at active surveillance for the slow progression, or for the moderate progression with moderate to high tumor burden, are we looking at the radionuclide therapies, the TKIs, or in the situations where there's rapid progression or high visceral tumor burden, are we focusing on cytotoxic regimens? And always the consideration for what available clinical trials are out there. And so the chemotherapy story has been one in which it's been based mostly on small studies or retrospective analyses. And so CVD or cyclophosphamide vincristine dacarbazine what has been a standard of care for the more aggressive variants of metastatic para and Pheo based on the Averbach results in this non-randomized single-arm study. There's very reasonable tumor responses in this very small cohort of patients. With the development of temozolomide with its similar mechanism of action to dacarbazine and safety profile that was a bit more tolerable than the 3-drug regimen, retrospective analyses have demonstrated that there is reasonable efficacy and tolerability to the use of temozolomide. And then it's the targeted therapy story. And this I took from our moderator, Dr. Jimenez, is one of his reviews. And it's just a nice depiction of all the different varieties of options that we have. This next section just to highlight the variety of targets that the TKIs will focus on, some of the new therapies like the HIF-2 alpha inhibitors, and then the radionuclide therapies that Dr. Pandit Taskar had reviewed. All are very well depicted in this cartoon graphic. And from the TKI standpoint, there are 2 trials that demonstrated the benefit of sunitinib in this patient population. These 2 studies varied a little bit in that one was a single-arm study. The dosing schedule was different than the second study. The toxicity profile was very similar, fatigue, hypertension. But what you can see is that the PFS in both trials was notable. And in the first MAP study with the comparison to the placebo, you can see the benefit of sunitinib in patients with this disease. Other TKIs that have been evaluated, I've included here in this very busy chart, so I apologize for that. But you can see that there are all these trials are meeting their primary endpoints and demonstrating pretty reasonable response rates with similar side effect profiles. And I will very briefly go through this to not take away the platform on which Dr. Sukrithan is going to be reviewing new trials that are coming up. But one that's near and dear to my heart is the Alliance trial looking at PARP and temozolomide, and this was based on preclinical work by Dr. Peng and colleagues, in which they demonstrated that cluster 1 Pheo paras do develop a dependency on the mitochondrial complex, and there's upregulation of that complex and enhanced NADH dehydrogenation. And so in the preclinical, in their preclinical studies, they did show that PARP inhibitors plus temozolomide and SDHB knockdown Pheo para allografts did result in cytotoxicity, a reduction in metastatic lesions, and a prolonged overall survival. And again, just briefly, this is a study that is currently active and looking at that combination and randomizing patients to temozolomide versus temozolomide and olaparib. As of June 1st, we have enrolled 22 patients to the study. And again, I'll just briefly touch on this because again, I don't want to steal the thunder of my colleague that will be following up, is the belzutifan story. So I will just move quickly through this slide and onto the immunotherapy. So as with many other cancers and other neuroendocrine tumors, there has been studies looking at the role of checkpoint inhibitors in rare tumors, and specifically in this study that was published in 2020. Here you can see that the Pheo cohort is this light blue group. And of the 9 patients who were evaluable, 8 of which had a response, 6 had met their response criteria by immune resist parameters and met demonstrating stable disease, and also demonstrated disease control greater than 4 months, which was the primary objective of the study. As we know, in many other neuroendocrine tumors and other diseases, the single agent checkpoint inhibitors is just not going to be the home run that we are hoping that it would be. So there is this exciting study that is active looking at a novel therapeutic vaccine, EO2401, which is a cancer peptide therapeutic vaccine. And it is one of the cohorts does include patients with metastatic or treated or untreated Pheo. Some of the prelim data suggests that there is some clinical benefit to this vaccine, but obviously the numbers are small, and we'll await the final conclusions from the study. And finally, I'll end with the radionuclide therapies. Again, just briefly, this was already discussed in detail by Dr. Panditaskar. The study demonstrating the benefits of Azedra in this patient population and the very notable improvements in median overall survival and the tolerability of the treatment. With PRRT, as you mentioned, there have been many efforts looking at this this therapy in patients with Pheo, and in these small cohorts, there has been demonstrated response with reasonable partial responses as well as stable disease. And as she mentioned, there's been response based on mutation, and in this trial that was presented at ESMO, there was a correlation between the presence of SDH mutation and with progression-free survival. And a current active study that is ongoing at the NIH is looking at Lutathera specifically in patients with inoperable Pheo-paras. It's a single arm phase 2. There are 2 patients are stratified to 2 cohorts. Data was recently presented at SNMMI regarding the interim analysis results. And so of the 36 patients prior to the interim analysis, 31 of the 36 met PFS at 6 months, and median PFS was 19.3 months. What I thought was interesting from the abstract was the AEs compared to the package insert. Myelosuppression rates were similar. Liver toxicity was improved with the Lutathera group compared to the package insert. Hypertension was higher, which would be expected, as well as a phenomenon called catecholamine release syndrome. And it was noted that that did occur in patients, which could be as soon as infusion of the treatment and could last up to 2 weeks after the treatment. What was also notable was the development of pituitary and endocrine side effects, which have not been reported associated with this treatment. So I'll finish again with the algorithm that I started with, which is we have a lot of great options. We always want to think about clinical trials. We want to keep patients' disease burden and rate of progression in mind when we're deciding how to strategize their treatment profile. Right now, with the new data that continues to come out, I think some personalized approaches that you can consider is with the SDH mutated tumors, consider temozolomide or the alliance trial with PARP inhibitors. With cluster 1 tumors, you can, especially the ones with HIF2 alpha mutations, you can consider the belzutifan study, cluster 2, tumors that fall into the cluster 2 category, consider the tyrosine kinase inhibitors, and then the SST or expressed tumors, lutetium dotatate, and then the norepinephrine transporter system expressed, the AZEDRA or IMIBG therapy. Again, just suggestions, but that is the end of my portion.
Thank you, Dr. Perez. That was a very, very nice presentation. Now, finally, let's hear from Dr. Sukriten. And welcome.
Thank you, everyone. So I had the unenviable task of continuing after Dr. Perez, when a lot of it has already been discussed, but it's still a great pleasure and privilege. So I'm going to touch base briefly on ongoing clinical trials and future directions in pheochromocytoma paraganglioma. Once again, I'm Vineet Sukriten. I'm an assistant professor of medicine in the Division of Medical Oncology at Ohio State University. These are my relevant disclosures. So the learning objectives for today are basically to just re-review some of the relevant pathways that you've been introduced to from the previous speakers that are targets in pheochromocytoma paragangliomas, to review some of the ongoing clinical trials in this space, and to just touch upon, discuss, and future directions for clinical trials in pheo-para. So just to introduce certain terminology that we use when we describe phases of clinical trials. Phase 1 trial refers to studies that are done mostly to assess safety of newer medicines and to figure out the right new dosage of the medicine. Usually these are smaller studies with around 20 up to 100 patients or so. They last a few months, up to a year or so, and around 70% of drugs, we believe, move on from phase 1 to phase 2 after they meet their goals. A phase 2 study also looks at efficacy and safety. These tend to be slightly larger studies, may be up to 100 or a few hundred in number. The length of the study can be anywhere from several months to up to a few years. And around 33% of medications that pass phase 1 also are successful in phase 2. And at this point, the trials, the medication center was called a phase 3 trial, which tries to compare different treatments to each other. And the goal of these studies, the larger phase 3s, is also efficacy as well as safety. But these can have many hundreds of patients. It can last many years. And again, another 25% of these drugs ultimately end up being positive studies and end up getting FDA approval. So as you can see, it's a long and arduous process with a lot of pitfalls. The first group of treatments, which you're already familiar with and has been touched upon, is treatments that target what's called the SSTR2 receptor. The SSTR2 receptor are present on the surface of 50% or more of pheo-para patients, and it does correlate with the SDHB mutations. These are basically receptors for somatostatin that are present on the surface. And because neuroendocrine tumors such as pheo and para do have this, it is a nice target that has been of interest for researchers for some time now. These receptors can be targeted using compounds called SSAs, which are somatostatin analogs. These are synthetic compounds that are analogous to the natural hormone somatostatin that is present in our bodies, but it binds to SSTR2 receptors with greater affinity. And we think it blocks the pathway with much greater efficacy than the naturally occurring somatostatin. So SSAs have been used for treatment for some time now, but the efficacy is still improving. So one of the first studies that I want to talk about briefly is this exploratory phase 2 study of lanreotide in metastatic patients called LAMPARA. Lanreotide is a somatostatin analog. This trial has an estimated enrollment of around 40 patients or so. We expect it to complete accrual sometime in the next year. This is the trial number that you can look up on clinicaltrials.gov. And in terms of key eligibility, patients should have prior progression of the disease And somatostatin receptor scintigraphy needs to be performed within 6 months before getting on the study. The second way of targeting SSTR2 receptors, which you're familiar with from prior speakers, is the concept of peptide receptor radiotherapy, specifically lutetium-177 dotatate. I'm just going to explain it fairly briefly using this figure. So a way to think about lutetium-177 dotatate is by going from left to right. So lutetium-177 is the radioactive nuclide that produces or releases the radiation. So that's the Lu-177. DOTA is a linker or a chelator, which kind of traps the lutetium as well as links it to this peptide, which is called octreotate. So that's a peptide. So you have the lutetium that's linked to the DOTA that's linked to the octreotate. So that essentially explains the entire compound. And now this compound, through a lock and key mechanism, finds its way onto the SSTR2 target present on the tumor surface. And by releasing the radioactive payload, is able to kill the tumor. Now, lutetium-177 is a medium energy emitter of beta radioactivity. This has an energy of around 0.5 MeV and a tissue penetration of 2 millimeters. So this compound is already approved to treat gastro and pancreatic neuroendocrine tumors with FDA in 2018. But we're hoping that with some of these studies that I'll describe, that we will have this option for our patients. So there's a smaller study called the Safety and Dosimetry in Adolescent Patients that's open to 8 patients, sponsored by Novartis. But the largest study is what has already been referred to, which is a study of Lutathera, which is lutetium-177 dotatate, in the therapy of inoperable patients. This is the largest study. The aim is to enroll up to 90 patients. The sponsor is the NCI. The PI is Dr. Frank Lin. And you've seen some preliminary data already, which does show some good activity. Just to keep in mind, the key exclusion criteria are, it is really not open to patients with mutations such as VHL1, VHLNF1, and RET. It's really targeting the SDH population. You can be on somatostatin analog therapy, but it should not be initiated or altered within 3 months of study enrollment. Now, another way of essentially administering radioactivity to these tumors is by something called PB212-VMT. So similar to lutetium-177, so lead-212 is another radionuclide, but the difference is that lead-212 undergoes alpha decay and releases alpha radioactivity. Alpha particles, when compared to beta particles, have a much higher energy in the range of 4 to 8 MeVs, and a very short path length in human tissue that we think is below 0.1 millimeters. What this means is we think that the amount of radioactivity administered is higher, which would increase the potency and efficacy. But also because the path length is shorter, we think that some of the other side effects of the beta emitters may be mitigated using this strategy. So this trial, the targeted alpha particle therapy for advanced SSTR2 positive neuroendocrine tumors, also includes Pheo paragangliomas. They hope to enroll 52 patients. They hope to dose the first couple of patients sometime late in summer this year. And inclusion criteria, patients who have had progressive disease on any approved therapies other than radionuclide therapies are eligible for this study. The second strategy is just shifting gears a little bit, moving away from the somatostatin receptors, is to target the formation of blood vessels in the tumors and strategies that the tumors use to escape from low oxygen environments. So one of the proteins that tumors use for this purpose is something called VEGF. VEGF is a protein that promotes tumor blood vessel formation, and anti-VEGF therapies such as sunitinib have shown efficacy, and Dr. Perez has shown some slides regarding that. So an ongoing study is one of another medication which also targets this protein called axitinib. And this is a study of axitinib with evaluation of the pathway in pheochromocytomas and paragangliomas. This study aims to enroll 25 patients. The exclusion criteria to keep in mind are large abdominal masses that are impinging on the bowel or pulmonary masses, which are close to blood vessels. As we do know that one of the the class side effects of these medications is sometimes it can lead to some bleeding issues as well as fistula formations. So these patients will need to be discussed with the sponsor on a case-by-case basis. The other major side effect to keep in mind is all of these medications can increase the blood pressure. So blood pressure needs to be less than 150/90 before patients can be eligible for this trial. The second compound or molecule that targets oxygenation and hypoxia is belzutifan, which Dr. Perez has also briefly mentioned. So this trial, the belzutifan for the treatment of advanced Pheo pancreatic neuroendocrine tumor and VHL-associated tumors is currently ongoing. So belzutifan is a compound that targets a protein called HIF2 alpha. This is a protein that helps tumors survive in low oxygen environments. This compound is already approved for patients with the VHL1 Hippolyta syndrome who need treatments for their cancers, which can be RCC, renal cancer, some certain brain tumors, as well as certain pancreatic neuroendocrine tumors. This is the largest study. Total enrollment is more than 300 patients. And you are allowed to receive this even in frontline if there is no satisfactory treatment option or if patients are not a candidate for any other systemic cancer or chemotherapies. Similarly, this trial also requires that blood pressure be well controlled, less than 150/90 for adults. And blood pressure medications need to be well controlled and stable for at least 2 weeks before we can start this treatment. The third strategy is augmenting the DNA damage within tumors. And the trial that I want to highlight is the prospective phase 2 trial. It's a randomized study of temozolomide versus temozolomide and olaparib, which Dr. Perez and Dr. Del Rivero are leading in our patients. So olaparib, which is this, the compound of investigation, is a PARP inhibitor. And PARP stands for poly-ADP ribose polymerase. So these are essentially proteins that can help repair DNA damage in tumors. So we think that by inhibiting these DNA damage repair genes and proteins, we can augment the efficacy of temozolomide and hopefully lead to a better tumor control. So PARP inhibitors, such as olaparib, can keep the PARP from working well, and so these tumor cells can repair the DNA by themselves. The aim of the study is to compare progression-free survival, which is the amount of time that patients go without the disease getting worse, and to compare the combination with temozolomide by itself. And this trial seeks to enroll around 76 patients. Lastly, is our immune strategies, which have also been touched upon, the EO2401 compound. It's a multi-center phase 1/2 first-in-human study that's looking at basically a peptide vaccine called EO2401. So this includes, essentially it's a vaccine that has proteins that are very closely similar to certain proteins that are on the surface of tumors, specifically IL-13, BRC5, FOXM1, as well as 2 other proteins that we think will help it engage the immune system. The main things to remember in terms of exclusion criteria are prior immunotherapy, radionuclear therapy, radiotherapy, and cytoreductive therapy. Briefly about future directions, I think combination strategies are the way to go. I did touch upon the combination temozolomide and olaparib, but I think there are other avenues as well that we can explore. One of them is kind of combining radiopharmaceuticals that produce radioactivity, such as alpha beta emitters, etc., with medications that have a different side effect profile, like ones that can target tumor blood vessels. This way we can get maximum benefit with the least amount of additive toxicity. I think the second strategy that I can also talk about is combining compounds that target hypoxia like belzutifan in combination with immunotherapies. This is ongoing strategy that's been studied in renal cancer and other tumors and has some preliminary efficacy. So I think that's another avenue that we can explore in our diseases as well. Finally, this is our multidisciplinary team here at Ohio State. It includes myself, a medical oncologist, Dr. Kirshner in the middle, who's an endocrinologist, and Dr. Barb Miller, who's our expert adrenal surgeon. With that, I'd like to end, and we can open to questions at the end of the presentation. Thank you.
and Dr. Sokritan. That was a lovely presentation. So thank you all, really. Thank you very much for all your talks. They are very, very nice. As a reminder, if you want to claim credits for this webinar, please visit the website list. Now, let's open the floor for questions. Please place your questions for our presenters in the question and answer box. And I think we already have one question, or well, it's been answered. And it was answered in the chat, I think, by Dr. Pandit. Okay. Is it okay if I repeat the question just in case to the whole audience? Let's start with that question because I found it actually quite interesting. This is a question coming from Dr. Mitra. And he asked, can you please talk more about the 250 millicuries dosing for etc. that would allow for outpatient therapy? Is that approved? Is it reimbursable? How is it spaced?
So it's definitely a tough thing to answer. So just as probably everyone knows that, the recommended dose for the Izidra, which is the FDA approved agent, is essentially 500 millicuries given 90 days apart. It's because of the high, let's say if the dosimetry calculation comes out to the 500 millicuries is meeting within the dose limits of the organs, you will end up giving that to the patient twice. And this would mean that these patients would have to be treated as an inpatient, which I think that, many times in terms of the reimbursement and it creates a challenge because one, the logistics of inpatient treatment, plus also the reimbursement and recovering the costs may not be very economically feasible to many, or may not be favorable. So I think the 200 millicurie dosing, based upon the experience that we've had with the conventional over the last 2 decades, definitely is possible, and I don't see why we cannot follow the same schema of giving 250 millicurie, which can be given as an outpatient. The reason we say 250 millicuries is that in many institutions, and depending on what state you belong to, you can give that as an outpatient treatment. So if you say that, we have experience with conventional MIBG, where people gave fractionated doses between 200 to 250, and especially we have treated over the last 2 decades patients with that dosing, let's say every 10 to 12 weeks apart, ensuring that the patient recovers or has his all the parameters within the required limits and no side effects. So with that, we can give up to 3, 4, or 5 dosing and then space it out, and the patient can follow up and get even more. So can we follow that? I think clinically, I don't see why that is, that we can't do that, because it's the same agent, in fact, has a higher, let's say you can say, expected potency or higher specific activity. So it just seems like clinically you can give and would expect the same kind of, hopefully, responses. I think the insurance bit is a bit tricky. I think if upfront the patient is approved for a total dose, which actually we have obtained for at least 1 or 2 patients, especially with other treatments also, that if you just say that you have X amount of millicuries that you've calculated and that's going to be given to the patient, then it gets approved, and you can then define how you're going to split up the dose. I'm not sure, and I can't speak for the insurance coverage across different institutions and different carriers, but that's actually a difficult logistical question. But clinically, I think I don't see any clinical reason why we cannot follow the same paradigm and or the same schema and give it to patients.
Just to ask to the whole group, have you ever treated someone, for instance, with doses of 200, 250 millicuries in your clinical experience recently? Have you had that chance?
No, I haven't.
Because I can tell you from my side, of course, this is a medication that is very new. The medication was approved in 2018, and 2019 was when really we started using it after it was approved in clinical practice. And it's quite interesting because of a historical event by now, if you want to call it historical, although I think it still continues and will continue forever, which is COVID. So with COVID, we had a lot of interruptions in how this medication was prescribed in clinical practice. So for instance, we had patients who were scheduled to receive 2 doses and were not able to receive a second dose because everything was interrupted because of the COVID outbreak. Now, what it was interesting in what I consider or I call a real world experience is that several of these patients that, for instance, we treated at MD Anderson with only 1 dose of high specific activity, MIBG or etc., in reality of follow-up, we were checking on radiographic and biochemical studies on how they were doing clinically speaking, and they were doing very well. Up to the point that, of course, I cannot prove this in clinical practice, scientifically speaking, but based on experience, I have seen patients who I treated with only 1 dose of this medication, and they have done remarkably well. I cannot say that that's for everybody, but maybe for a group of patients, maybe with not a lot of disease or disease that is easy to respond to the medication, you may have that opportunity. In the same order of ideas, and there is a case report published in Clinical Nuclear Medicine, you will see that we treated 1 patient who was 44 kilograms of weight, and he is currently 84 years of age. He's very, very, very tiny. And of interest, we gave him a dose equivalent to 290 millicuries total. He has had one of the most impressive responses to the medication ever that we have seen in our clinical practice. And of interest, the patient didn't have really any side effects. It's the only patient of all I have treated with no really side effects. So it's quite interesting to see this. In other words, I still believe that we have to learn more about these medications. And in that order of ideas, I would like to ask all of you, of course, about experience, although I see some other questions. There is a question here from one of the attendees. Is Acedra the same as PB212 VMT?
No, these are very different targets, and as I mentioned, the MIBG is targeting the norepinephrine transporter mechanism, and the lead VMT is an entirely different target. But I'll let Dr. Sukrithan talk about the VMT.
Yeah, I just want to reiterate what Dr. Panitaska just mentioned. Yeah, so the target is, again, SSTR2 receptor in the lead-212, so similar to lutetium-177. It is targeting the somatostatin receptor 2. It's just that instead of lutetium-177, which releases beta radioactivity, this is an alpha emitter. But it's not the same as the Acedra.
Very good. And really, there is another question that I think is important for the whole group, for the whole audience. Do we have to prepare patients with alpha blockade before therapy in the case of, for instance, high specific activity iodine 131 MIBG therapy? That I think is a question coming from Dr. Mitra as well. And it also is a question that is extended not only to this one, it's extended to Lutathera as well. So, and I think all of you talk about that. So whoever wants to answer, please take care of the microphone.
Yeah, so generally we just assess the patient, as also mentioned in talks, that many of these patients do have hypertension to begin with. Generally we want the patients to be stable, and because we could have fluctuations in blood pressure during administration, both hypertensive as well as hypotensive. But more so, I think the more we control upfront the hypertension aspect of things, the infusion and the side effects go more smoothly. So we generally have all the patients assessed upfront to ensure that their blood pressures are stable and generally move them to the alpha blockade. Doxazine is the agent of choice. So that's what we do. So short answer, I think, is yes.
And Dr. Perez, you mentioned some of the preliminary results of a clinical trial with Lutathera, and there was hypertension reported in those patients. Did you see any report of hypertension, for instance, in the clinical trial with Acedra or high specific activity MIBG?
Not to the same extent. So I'm curious to see how the Lutathera trial will, with the addition or expansion of additional patients, if that hypertension or catecholamine related symptoms is going to be more pervasive than what was reported with the Acedra results.
Yes, it's quite interesting because if you look at the only clinical trial with the conventional MIBG, the old MIBG trial that was published by Dr. Gonias in 2008, in that trial, they identified that 10% of patients develop a hypertensive crisis during the infusion or immediately after the infusion of MIBG. Now, they were using very high doses, as Dr. Pandit Taskar mentioned in her lecture. But when you look at the phase 2 clinical trial with high specific activity other than 100 MIBG or Acedra, in reality, there was no a single case of hypertension or difficult to control hypertension during the infusion or immediately after the infusion. And that has led many researchers to think about what is the reason for that. And the FDA believes that likely has to do with the fact that the medication is much more refined, and therefore there may not be a potential analog action on the alpha receptors just caused by the old MIBG when compared with the hot one that likely will not have that effect. Saying this, I still prefer to prepare everybody who goes into treatment with high specific activity, iodine 131 MIBG, with alpha and beta blockers. It's safer. But if you ask me, I think in the real world experience, we don't see that as an important side effect, which is important to consider here. Now, let me see, because I see another question. This is coming from Paola Jimenez. What evidence we have in second line of treatment progression to Acedra? Do you prefer TKIs or chemotherapy? Very interesting question.
I'll try that one. I think similar to other neuroendocrine tumors, we don't have sequencing studies. So I think, you were really left to extrapolate the data from the phase 2 study. And if a patient's disease starts to take on a phenotype that would suggest that MIBG, because their imaging suggests it would be an option, I think you should consider it. But whether or not, and I think time will tell whether or not doing MIBG or radionuclide therapy followed by TKI, followed by alkylating agents is going to prove to be an issue, specifically from a hematologic standpoint. I think time will tell, but I do think we have to be thoughtful about that part of it.
That's very important. I think the question is quite critical because in the world of pheochromocytoma, paraganglioma, we try to think many times based on genetic genotype and to make decisions just based on that. In my opinion, I think we are still a little bit far away from that. And I think this is a concept that I want to discuss with all of us. Dr. Perez, your slide was very interesting. You mentioned that for cluster 2, you would consider tyrosine kinase inhibitors as potential of a very good option for those particular patients. Now, when you look at cluster 2, yes, we see metastatic disease, but in reality, most patients are not metastatic. And to give you examples, we are talking about multiple endocrine neoplasia type 2, where you may see maybe 1% of cases of metastatic pheochromocytomas. Paragangliomas are exceedingly rare in that particular condition. TMN 127, when you may have less than 1% of metastatic cases, and maybe neurofibromatosis type 1, which is the one that may have a higher potential for being metastatic, although that one has a clear phenotype. And if you look at the clinical trials that have been done with tyrosine kinase inhibitors, because of the rarity of these conditions, yes, only one, the SNP trial that was described by Dr. Perez, the study from Canada, had one patient with multiple endocrine neoplasia type 2, but all the other trials didn't have any evidence of cluster 2 patients, and the medications work in those other individuals, which are mainly cluster 1. So my question to all of you is, do we really consider TKIs as priority for cluster 2, or can they be used for cluster 1 as many other medications could be, Dr. Perez?
I think I just trying to give cluster 2 an option, but I wouldn't say that it was dedicated only to that group. I agree with you. I think the molecular profiling is a guide, but I don't think it's dictating what our therapeutic options are. But there's just so much variability in the phenotypes of this disease, and so much more that we need to learn about it. And it's just trying to personalize what we do have available as much as possible.
And I think that's very important. And there are 2 more questions coming. Do you think that if you are SDHB positive, you cannot be treated with Acedra? What is your experience?
I wouldn't take anything off the table based solely on germline.
And I totally agree. It's quite interesting because I saw the study of a very neutral scientist from Germany with experience with low specific activity, MIDG, and those patients, many, were able to express the noradrenaline transporter, and according to her experience, they responded. And if you ask me in my experience, yes, I agree with you, Dr. Perez and Dr. Pandit and Dr. Sukritan. We cannot use a genotype for SDHB to say we cannot treat. We have to give them an opportunity to explore that option. Yes, they may be negative, but if they are positive, why not? At the end, our resources in the real world are quite limited. So I think that's an important aspect here. And finally, I know the conversation is very interesting, but there is a question from Paola Jimenez, who I think is going to be a speaker in Canada. And really, thank you for being here with us this evening. What is your experience about metronomic temozolomide after CVD chemotherapy? Very interesting, Dr. Perez.
I can't say that I've done that, but I think the limited data that is out there suggests that the tolerability may be, the profile may be a bit better, but I don't think we have enough even retrospective data to say that that is a pathway that you should follow versus, kind of the dose dense schedule of days 1 through 5.
And if it was your case, Dr. Perez, let's say that someone has experienced substantial toxicity with CVD, but the patient has responded, would you consider taking a risk to move CVD to temozolomide? Just asking.
I don't think so. We always want to use what we know works and where the benefit is, right?
Okay, very good. Very good. Let me see, I know it's 7:08 and I'm going to ask the NANETS. The conversation is very interesting. Can we continue or not really? Ms. Cassandra.
You are welcome to continue if the panelists have time to stay.
Does everybody want to continue? Because I want to learn more about you. Is that okay? So let's continue because there are very interesting conversations here. Anemia. It caught my attention, Dr. Pandit. In your lecture on high specific activity iodine 131 MIBG or Acedra, you mentioned that we shouldn't give it when patients have platelets that are below, I think, 80,000 and neutrophils below 1,500. But there was no comment on hemoglobin on hematocrit. What do you think about that?
So, yes, generally, if there is a low hemoglobin, the side effects are mainly related to, the hematologic toxicity, and we find that the most sensitive, cells are, platelets, and the side effects on that can have consequences. Now, with hemoglobin, generally with these treatments or generally radiopharmaceutical treatments, doesn't affect, the hemoglobin as much, but just like in other treatments also, for example, Pluvictos and Lutathera, there's always an absolute, and it could be 10 or 8 that we can say, it's just because the tolerance may be lower to not use it. But that I personally feel hemoglobin is not as limiting in terms of what dosing you administer, and I would not have a high cutoff for that, and I would just make it very low, just because of the concern of very low hemoglobin would mean that patient may not be very able to in terms of physical tolerance, but I think the side effect wise there is less concern about hemoglobin than other parameters. I don't know what your
And
experience has been.
Dr. Perez, Dr. Sukritant, do you have any experience on that?
Yeah, I'm going through something similar situation for a patient. Currently, the hemoglobin is a little bit on the lower side, but just as you said, the label doesn't actually require a hold based on that. The platelet issue is actually also, especially because you've said, like, if you have platelets of less than 50,000 active bleeding, that's an indication to dose reduce. So I have an ongoing patient where we are planning to augment the platelets a little bit because I'm starting to notice some, very mild hematuria in a patient. So I think these are all very active, interesting clinical questions we face on a day-to-day situation. I mean, personally, I do think that, the hemoglobin, once I start to see numbers that are close to 7 and symptomatic, I would transfuse them and support them. But I'd like to know, what your experience has been in terms of, like, have you ever done a dose reduction for anemia, for example?
Dr. Pandit? It seems that you said no.
No,
right?
we haven't. You're right. I mean, not just with MIBG, but even other treatments. If you have someone with low hemoglobin, but definitely requires the treatment, like you said, you could transfuse, stabilize the patient, bump it up, and then subsequently treat.
And I think this is a very important point because people many times wonders about this issue. And we have to remember that pheochromocytomas and paragangliomas, whenever they spread, they like to spread very much to the skeleton, and the bone marrow is affected in about 80% of patients. It's quite interesting to see this. This is one of those cancers, together with breast and prostate cancer, that likes the skeleton very much. And of course, as the options are limited, and many times what we have is just chemotherapy with CVD. Yes, many of these patients are exposed to CVD chemotherapy, and on top of that, you develop some bone marrow insufficiency. And furthermore, these are patients who get radiation therapy to prevent skeletal-related events, and then you have a bone marrow reserve that is somewhat suppressed. In my experience, I have had to treat some patients with anemia. Of course, I'm not going to take someone who has a hemoglobin, as you described, of 4 or 5 to treatment with high specific activity, higher than 131 in MIBG. But sometimes that's the only option that we have. So I have treated individuals who have what we call grade 1 or grade 2 anemias. They are prepared very well. They get transfusion many times as support. And then later, we continue with close follow-up with periodic CVCs, and if needed, of course, we provide support. And I would say that, although I may be biased, because it's just my experience, we've been able to continue providing treatment to several of these patients. Now, another important aspect here is that it's been told that bone marrow insufficiency happens in all these patients. No, it happens in 60%. Yes, it's a high number, but in reality, all patients in the clinical trial recovered, although yes, up to 25% of them require supportive measurements, and at the end, they were able to survive. Whether these medications later on may predispose to bone dysplasia or leukemia, I suppose is still to be determined, although we know that likely we'll see one day one of those happenings, as has been the history of this before. Now, it is 6:14, and I've been asked to finish this presentation by 7:15 p.m. Eastern Time. There is one more minute. Dr. Sukritan, Dr. Perez, Dr. Pandit Tashkar, any comments, anything that you want to share with our audience? Or let me see, it seems that there is also a question from the audience, or not really, but anything that you want to share.
Just keep the clinical trials in mind. I think we need to continue to learn. And I think as we add correlatives to our clinical therapeutic trial efforts, that's only going to move this disease, options for this disease further.
And
Yeah,
I totally agree.
Yeah,
In
and
the
I
ideas
agree.
that
And
come in there.
yeah, sorry. I also agree. And, Dr. Sukrit had mentioned about, combination alpha betas and combination therapies with other targeted agents. I think that's another area to explore. And, some have also said MABG, which is again an alpha emitting agent. But again, these are all experimental, but we need clinical trials to see where we can use these and improvise outcomes.
Important part is that there are new horizons and new hopes. And just to let the audience and all of you know, really, it has been a wonderful session. Dr. Mitra comment here that thank you all very much. Very informative talks. And Dr. Paola Jimenez says, thanks all for an excellent conference and discussion. So with this, really thank you all for your efforts, your work, and for bringing hopes to patients with pheochromocytomas and paragangliomas. And from wherever you are, I wish you a wonderful night. In Houston, Texas, it's very hot and humid. I hope you are cooler and fresher wherever you are. And thank you for the opportunity to share the podium with all of you. And good night.
Thank
Thank you,
you
Dr.
very
Mendes.
much. Good night.